Cindy said, I really want you to talk more about uncertainty, but in the context of DSD. So a lot of what I'm going to be talking about today really has to do with this whole concept of uncertainty and how it's been a part of our research over the course of many years. So I'll talk a little bit about our research on the construct of uncertainty. We're going to talk a little bit about some of the interventions that we have developed for kids with type 1 diabetes and cancer. And then we'll go ahead and talk a little bit about the research that we've been doing in the last 8 to 10 years in the context of DSD. So first off, I need to acknowledge Amy Wisniewski, who has been my colleague for many, many years. I would not be here today if it wasn't for Amy's influence and input. She was the one that introduced me to this world of DSD and has been instrumental in every facet of what we do. So I want to make sure that everybody understands the critical role that Amy has played in all of this and continues to play in working not only in the research, but also in mentoring graduate students. I'm going to go ahead and acknowledge a lot of people just right up front. You can see the list there of former graduate students, current graduate students. A number of you are on this call today. So this is kind of a shout out to you. Christina Sorsa, David Fideli, Steph Holman, Angelica Eddington, Courtney Wolf Christensen, Kate Gamwell, Ali Delosier, Dana Bacala, Christina Sharkey, Megan Perez, Katie Traino, Rachel Fisher, Caroline Roberts, Marissa Badino, Nathan Basile, and Taylor Morgan, among others. And I have to acknowledge people because I don't think any of us in this field can get anything done unless we have a village to carry us. I also want to thank Christy Reyes, who's been coordinating our grants and is in the trenches, as well as our undergraduate coordinator, Morgan Pepper. So, and the 12 sites that have been a part of this very, very large project over the last 7.5 years. So just so you guys kind of know, I am an Okie. I get to use that term because I'm from here. It's not a pejorative term. It says everything and nothing at the same time. It's also important to understand that Oklahoma is the birthplace of pediatric psychology, going back to Logan Wright. We are known for tornadoes, hailstorms, wildfires, and earthquakes. We lead the nation in per capita in FEMA dollars. And this was an actual sign that was put up on one day a number of years ago. We had an earthquake and a tornado in the same day. So, and the following week I drove through a wildfire. So we have a sense of what resilience means. So I'm not going to tell any fish stories, well, maybe a couple. Okay. So our team in Oklahoma has really had this long-standing interest in looking at predictors of coping, what it is that sets the stage or groundwork for coping, whether that's positive coping or negative coping. We all know that most of our families on a good day are doing relatively well, at least as it concerns traditional measures of psychopathology. Parents of kids with chronic health conditions, the kids themselves, by and large, tend to adapt. But we also know that there is a subset that do not do well. Our goal has always been to try and identify these predictors, and hopefully we're trying to identify predictors that are malleable, that are changeable, so that we can then develop interventions. Because it's our notion, I mean, we know that CBT and ACT and mindfulness and all these other interventions work in different contexts with our kids and their families, but what if we can actually enhance the impact and the efficacy of these particular interventions by identifying these predictors? Okay. So again, historically, the idea has been, well, everybody does well, right? I had a conversation with my good friend Sean Phipps a number of years ago, who's often referred to as the dour Irishman, who said, come on, I don't know why we're doing all these interventions. Everybody does great. He goes, now don't ask me why I'm developing interventions for these families, but by the way, they all do great. Again, they're resilient in lots of ways. But my argument has always been that even if on paper and pencil measures they're doing well, I don't think that any of us would argue that these families' lives are changed by the chronic illness. in subtle ways and not so subtle ways. I would argue that these non-normative events, as some people call them, change the trajectory of one's life potentially. And so our goal is to facilitate that in whatever way we can. Okay. So why uncertainty? Well, I remember being an undergraduate and learning about those lab studies in which rats, dogs, animal studies were given an opportunity to experience either predictable or unpredictable shock. Okay. As an animal lover, I'm not going to advocate for this research, but in any case, what was compelling to me is that whenever the rats, the dogs could anticipate the shock, they responded more favorably, less distress, less psychophysiological arousal. Actually found a great 1979 Psych Bulletin article that documents study after study. Given a choice about predictable versus unpredictable events, we want predictability in our lives, okay? And in the absence of control and predictability, as human beings, we tend to struggle, okay? I don't think anybody would argue with me that people like to have a certain level of control and predictability, even in a pandemic. So we even went so far as early on, John Chaney and I actually designed this study while sitting in a bar where we actually figured out how we could experimentally induce learned helplessness in college students with asthma to see how they responded and to see how they reacted to unpredictable events such as failing on a task. But that's another story for another day. So along the way, I'm trying to find measures of control, contingency, predictability. And I cannot recall the exact moment, but I ran into these critical articles by this wonderful researcher, Merle Michel, who unfortunately is no longer with us. Merle Michel developed this entire theoretical model of illness uncertainty. And it's interesting to note, Merle Michel, many of you probably know, she was in the College of Nursing at UNC Chapel Hill, but she was actually trained, her PhD is in social psychology. So she was really interested in cognitive processing, how people perceive events. So she discussed this whole notion. Usually her work was in the context of adults with a chronic health condition, adult cancers largely. She referred to illness uncertainty as this cognitive appraisal that's elicited in situations where the meaning of illness-related events are unclear, outcomes are unpredictable because there's insufficient information or cues are lacking. She argued that this illness uncertainty is a function of this interaction between antecedent events and an individual's subjective appraisal of those events and the potential outcomes. So Michelle's work really set the stage for being able to investigate using reliable and well-validated measures to look at how parents of kids with a chronic health condition and the kids themselves actually experience this illness uncertainty. All right. So it became a part of every protocol that we initiated in every population we could get access to. And over and over again, this measure rose to the top in terms of it being one of the single most reliable and robust predictors of adjustment in adults in both adult and pediatric populations. So across pediatric cancer, adult cancers, JRA, asthma, IBD, among many others, this seemed to be this incredibly salient predictor after controlling for everything else in the world. Okay. So we were really struck by this. And so we thought, well, look, if we can teach parents and kids how to cope with and manage uncertainty, then you would hope that their distress levels would be attenuated. So uncertainty kind of becomes the target of what we're teaching people to manage. Now, again, the argument here is that, we're not trying to make the uncertainty go away. We're trying to teach people how to manage it. Okay. So one other thing I think I really just kind of have to say to you all, again, is as we started the process of developing interventions, you know, all of our work revolves around a family systems framework, guides our work. You know, I say this, you know, probably preaching to the choir a bit, but the idea here is that we want to focus on the family system and have the biggest possible impact, okay? At times, our default position for many folks is just to work with the kids. But with that being said, of course, especially if you worked in a pediatric cancer population, you're probably not going to be doing CBT with a 3-year-old with leukemia, okay? So where do you operate in terms of changing the course of adjustment? So our studies also consistently were showing the other single best predictor of kids' adjustment, go figure, is parent adjustment. All right. So where are you going to get the biggest bang for your buck in terms of an intervention? Well, we argued let's go for the parents. Not that kid interventions are unimportant. Please don't get me wrong, but the focus would become more on the parents. Okay. So I don't know why I put that slide in there. Just seemed tangentially related to families. So Anna Hoff-Pye, who was a graduate student at the time at Oklahoma State University, decided that we would test a version of an intervention targeting parents of kids with type 1 diabetes with the aim of teaching them how to manage uncertainty. So we essentially wrapped a number of cognitive behavioral strategies around this target of uncertainty. And we developed essentially 6 modules. One module talked about the nature of uncertainty, what it was, how it's experienced by parents. One module consisted of a focus on teaching them various cognitive coping strategies. We included a problem-solving module just to teach parents basic problem-solving skills. We taught them and, in a sense, empowered them to communicate with their medical team, with the interdisciplinary team. We talked about the role and salience of social support, and then we had a module that talked about consolidation of these skills. So we put this together, not a lot of money, but just enough to get us through. So this was our early pilot intervention. We ended up with 34 families, including both moms and dads, administered our measures at baseline, 1 month post-intervention. These are weekend sessions that we did in the clinic in either Tulsa or Oklahoma City. What was interesting is that we saw in this intervention group significant reductions for maternal distress, parental distress, as well as maternal ratings of child behavior problems. We really didn't see any changes for the treatment as usual group, except for some reported reductions in child internalizing symptoms. Okay, so with this pilot, here's what we learned. We could develop the modules. The intervention was feasible. The parents seemed to really like it and rated it highly. It appeared as if we saw reductions in distress in the parents. What was interesting is that by parent proxy report, the intervention also seemed to have some downstream effects on child functioning. So parents reported their kids were actually doing better as well. Now, again, these are parents of kids newly diagnosed with type 1 diabetes. And as everybody knows here, these are parents who are wrestling with a lot of moving parts in those first 6 months following diagnosis. And we also realized that when we saw a lot of attrition for a couple of weekend sessions, that we really don't want to try and include dads during deer hunting season in Oklahoma, because, well, I won't go into their priorities, but we lost a couple along the way. Okay. So, so about this time, due to a host of reasons, I switched gears and left OSU and ended up in the Jimmy Everest Cancer Center at the OU Health Sciences Center as a research psychologist. And so I thought, okay, well, let's start looking at uncertainty more in the context of pediatric cancer. And so I started looking at Ann Kazak's work at CHOP, Saylor and Knowles' work with Sean Phipps, looking at problem solving, trying to figure out, okay, what are they seeing in terms of these their psychosocial interventions, which tended to be either problem solving or family focused interventions teaching CBT skills. Okay, so we decided to translate this to pediatric cancer with a slightly different focus. We decided that we would take more of an interdisciplinary approach, that again, it would be parent focused, and that we were going to embed this intervention in the ongoing clinical practice in the Jimmy Evers Center. One thing that we learned from Ann Kazak's research is that if you try and bring parents back in after their kids have completed treatment or bring them in for additional sessions, they really don't like to do it because it's traumatic for them and it exhausts their resources. Okay. So another kind of cute name, Pathways to Coping. This was our interdisciplinary intervention. We eventually received R21 funding for this. And just to kind of give you an idea of the sequencing here, what we essentially did was we alternated weeks with a nurse interventionist. And so we would have our first module being the nature of uncertainty, and week one would be both the psychologist interventionist and the nurse explaining the nature of uncertainty. And then we would start to alternate weeks where the first part of the module would be presented by the psychologist, and then the nurse would come back in and do a follow-up on those alternating weeks, because we wanted it to be more interdisciplinary in nature. Same set of modules though, a little more sophisticated in terms of their development. And I'm not going to go through all of this, but again, these were moms of kids between 2 and 18 years of age, diagnosed in the 4 months post-diagnosis. Okay, so 4 to 16 weeks out. Okay, all right. So, and again, we looked at baseline measures, post-intervention at 1 month, and then a follow-up at 3 months. Our measures included the Michelle Uncertainty and Illness Scale, Symptom Checklist 90. We looked at post-traumatic stress symptoms, as well as burden on the parents as our outcome measures. Again, these slides are a little busy, but what I want to show you here is that if you can see this, for reductions of illness uncertainty, we saw uncertainty coming down for both our intervention group as well as our treatment as usual. But if you look up here at the treatment as usual group, illness uncertainty starts to level off, where it continues to kind of go down for the intervention group. Caregiver burden, kind of a similar pattern. If you look at psychological distress, over the 3 time points, we tended to see distress start to come back up. What's mostly interesting to me, though, is if you look at post-traumatic stress symptoms, you see that post-traumatic stress symptoms starts to dip at time 2, and then it levels off and it stays level for the intervention group, whereas it starts to come back up for the treatment as usual group. Okay. So in this pilot study, again, the interventions seem to be helpful in reducing uncertainty, distress, post-traumatic stress, and burden. These were kind of medium to large effects depending upon the outcome measure. And again, take into account in the treatment as usual group, these folks are still getting ongoing psychosocial care as a part of their regular practice, including psychology and social work. Now, what was really interesting is that we went back and started looking at the scatter plots for this intervention, and kind of unexpectedly, what we saw is that moms in the intervention group either improved or didn't get worse. Whereas if you looked at the treatment as usual group, they worsened over time. And one of the individuals on the team at the time, Mark Chaffin, said, look, one of the things you guys may want to take into account is that even though you may not see these large scale reductions in symptoms, you're seeing some reduction. But he said, think about it this way. These folks are in the middle of their cancer care. The ones that are getting the intervention aren't worsening. And if you go back to that slide where you saw those post-traumatic stress symptoms start to escalate for the treatment as usual group, and what Mark kind of argued was, look, going forward, what you need to take into account is this may be an intervention that doesn't necessarily make everything better, but it keeps parents from experiencing worsening symptoms over the course of time. And, you know, we don't always think in those terms in terms of what our interventions do, okay? We want them to be effective. Sometimes, though, it may be that we want to get the Band-Aid on and just keep the infection from worsening. Okay. So again, this seemed to be kind of a viable option, this particular intervention. I'll be honest with you, it was not fun trying to still coordinate the scheduling between psychology and nursing. It was a challenge. We had a lot of missed sessions. That's one of those things you learn about in a pilot R21 is how things work. But it was clear that parents did like it and saw it as feasible and acceptable. Now, the other thing that we looked at is that we looked at, once again, downstream effects. So if you provide an intervention for the parents, what happens with the kids? Well, we saw this relationship between maternal distress decreasing and internalizing symptoms. Okay. In other words, the parent intervention seemed to have downstream effects with fewer internalizing symptoms being reported following the intervention. Okay. And we actually showed that the child internalizing symptoms effect was mediated by reduced maternal distress. Okay. Now, again, these are parent proxy reports. You know, and someone would argue, well, they're parent proxy reports, but and maybe this is just the glow factor, but it's worth looking at. So about this time, I was getting really tired, and I had returned to OSU for a lot of complex reasons that I'll share with you over a beer sometime. But it was a return to a warm, inviting environment. And one day I was talking with Anna, who had gone to Cincinnati, and we were talking about our old uncertainty intervention and the R21 results, et cetera. And she said, do you ever think about, you know, trying to get an R01? I said, no. And she goes, well, why don't you think about it? And I said, only if you lead it at Cincinnati. And she said, okay. And they had a huge bioinformatics core, et cetera. And so we used that pilot data to get this R21. So now we have this new project that's gone on for the last 5 years. And essentially what we have done is we have elected to try and test again the efficacy of the uncertainty intervention, focusing on parents of kids newly diagnosed with cancer. And this time we're using an education support group as a comparison group, which is a more active kind of intervention as a point of comparison. Again, it's going to be driven by this illness uncertainty framework. And this time, like everybody else in the world, we have an app. We developed an app. So we not only have the intervention taking place, but we also have the app, which I'll show you here in a little bit. And again, just kind of the basic aims, looking at the efficacy of the intervention on psychosocial functioning of kids with cancer and their parents. So we are going to essentially look not only at parent report this time, but also child report. We are going to also take a look at changes in uncertainty and time on the portal as a potential mediator of change, and compare the effects across pre-intervention psychosocial risk groups. So this time we're using the PAT to look at risk level for these parents to see if that makes a difference in terms of the impact of the intervention. Okay, and I'm just going to jump ahead here. So yeah, developing the app, that was a fun project. It looks really pretty. I like that part. Everything up until that point was painful. But that's what happens when you try and do it the right way and do focus groups and employ a large group of people who are into app development. It slowed us down a little bit, but this app includes lots of great features. We get, home screen. It's got a journaling capacity. It links into their medical record, at least on the Cincinnati campus. It has all the modules embedded in the app so that they can refresh their memory of the modules. It's got a calendar function. And again, at this point in time, we probably have follow-up on a handful of parents for the last time point, and we're at 279 parents. So we're 6 short of our target. So we're pretty happy with that. All right. Here again, the measures that we have utilized, the usual suspects, uncertainty, SCL-90. We include the social problem solving inventory, looking at PTSS, symptomatology. We've included the BASC, treatment acceptability questionnaire. The kids, again, when they reach 18 have completed these particular measures, we'll be looking at those and intensity of treatment. All right, so again, same modules that you've seen before. So I'm not going to belabor that. Here's kind of just what the app features look like according to the modules. Again, just lots of pretty pictures. I will tell you that trying to integrate apps with medical records is nightmarish because of encryption and layers of security, and it differs by hospital system. And so our programmers had a tremendously difficult time trying to make this work. So, of course, take into account, we started this project literally 6 years ago. So lots has changed since then, and apps are easier to develop with lots of great features. So what we learned, app development's difficult and expensive. Parents like the intervention, we know that. Once in the study, they tend to stay in the study. We also learned that multi-site RCTs are a huge challenge. And finally, what we haven't learned is whether or not it was effective. So in the next 3 to 4 months, we are going to be actively looking at our data with these last follow-up periods. All right, now I get to DSD. I took the long way. Okay. Gee, what is it that might create uncertainty in parents of kids with DSD or the kids? Well, this is a partial list. I don't have to tell you guys all the different dimensions and facets, ranging from the individual level to the cultural level, that lend themselves to creating uncertainty. Difficulties with diagnosis, lack of information that we still have about the nature of the various disorders that comprise DSD, debates about nomenclature, communication and decision-making in the context of DSD, gender assignment, as we were talking early, surgical decision-making, and we're now going into a new era, and Amy and I have talked about this many times. What's going to happen for these parents who can no longer get surgery at their site? Okay. Can you imagine the stress of that? So, okay. We still don't know a lot about the short-term and long-term medical and psychosocial late effects. This is still such an emerging area of science. We're still, I think, in the infancy of learning what we need to know. So once again, thanks to Amy, we wrote and secured The initial R01 back in 2013, seems like yesterday, right, Amy? She's smiling. This project has involved up to 12 different sites around the country. We renewed it and in 18, and so this is going to carry us into 2023 with this group of parents of kids with the DSD. So in a nutshell, this is a natural history study which tracks these kids shortly after birth. Okay, it's a prospective longitudinal design, and we're looking at medical outcomes, surgical outcomes, and a range of psychosocial outcomes. The psychosocial outcomes, and Amy's going to talk about this, I think, in her masterclass in the months to come. But we're focusing on depressive and anxious symptoms, post-traumatic stress symptoms, uncertainty, and decisional regret. So the psychosocial outcomes with the youth will focus on similar constructs using parent proxy report until the child reaches 8, at which time we'll get self-report. And we're edging closer and closer to when those kids will turn 8 and start to give us self-report measures, which will be really interesting. So again, take into account, because of the incidence, we've been accruing this data for a long time and building each year. And so as we have started to write up the results, take into account that this is a rolling number of parents of kids. Also take into account that we are getting both moms and dads. So in one of the first papers that came out, Christina Sorsa published in the Journal of Urology, just wanting to try and characterize the early functioning of parents with moderate to severe genital ambiguity. So here we were trying to look at early presentation before the age of 2 and before surgery, looking at anxiety, depression, quality of life, illness, uncertainty, and post-traumatic stress. And we also evaluated the relationship of assignment of child gender to parental outcomes. At this point in time, we had about 51 parents from 7 centers. Getting quickly to the results so that we have time for questions here. Large percentage of the parents were dissatisfied with the genital appearance of their child. And a small but significant percentage reported anxiety, depression, diminished quality of life, uncertainty, and post-traumatic stress. So again, in this initial subgroup, we demonstrated, again, we've got a subset of parents who are clearly at risk. And at least with this sample, a lot of the parents were not happy with the genital appearance of their child. Okay. When we looked at uncertainty, the levels that we saw, and again, this is not a clinical measure, the levels were comparable or slightly lower than parents of kids with type 1 diabetes or pediatric cancer, okay? But essentially equivalent to these other disease groups. Parents of boys and parents who were unsure of the gender of their child had greater levels of uncertainty. A later study by Courtney Wolf Christensen again looked at changes in level of distress after the child underwent genitoplasty. And again, trying to look at this brief trajectory, 6 months out in parents who elected for surgery. So the 27 moms, 22 dads. Essentially, there was no significant change in depressive or anxious symptoms or quality of life between baseline and 6 months. They tended to be kind of stable, although moms reported significantly higher levels of depressive symptoms than dads. Perhaps not a surprising finding. And while there weren't any changes in illness uncertainty over the time period, the level of illness uncertainty for parents of boys actually increased, while parents of girls reported no change. We've talked about this as a team before. Boys seem to have more issues, or at least related to their parents' experience of distress. We word that differently. Parents of boys seem more distressed at times than parents of girls. In 2019, Ali Delosier published this article looking specifically at uncertainty and post-traumatic stress and archives of sexual behavior. Again, in the interest of time, the aims here were to look at differences in ratings of illness, uncertainty, and post-traumatic stress for moms and dads, and differences on ratings of illness and uncertainty for parents of boys compared to parents of girls and parents of infants. Okay. So again, we're seeing moms reporting greater levels of post-traumatic stress, but not illness uncertainty than fathers, and we're more likely than fathers to report clinical levels of post-traumatic stress symptoms. Again, the numbers are not super high, but again, demonstrating the subset is at risk. Parent gender, undiagnosed or unclassified DSD status, and illness uncertainty were each associated with post-traumatic stress symptoms. Okay. So again, illness uncertainty serves as a predictor. Okay, just recently, Caroline Roberts looked at illness uncertainty as a longitudinal predictor of distress among caregivers. And again, here we're looking at the trajectory of the relationship between caregiver uncertainty about their child's DSD and anxious and depressive symptoms across the first 12 months following surgery, or if surgery was not performed, the first 12 months following study entry. Take into account that the vast majority of parents in this study have elected for surgery, making our non-surgical group really, really small and unable to make a lot of statistical comparisons. But here you can see we're up to 113 caregivers, a little over half being moms, completing their measures at baseline in 12 months following genitoplasty. Okay. What we saw, again, caregiver illness uncertainty in both anxious and depressive symptoms were highest at baseline and decreased slightly over time, okay? Across all time points, illness uncertainty, after controlling for other variables, predicted symptoms. So again, this robust predictor of outcomes. All right, so what can we conclude? Perceptions of uncertainty are highest soon after diagnosis. Uncertainty continues to predict both anxious and depressive symptoms. And one would argue that if there is going to be an intervention, then early is better than later. Currently, we have a couple other papers under review. Katie Trano has a paper looking at stigma and intrusiveness and distress in parents of kids, revised and resubmitted in Journal of Ped Psych. Megan Perez has a really neat paper where she is looking at the trajectories of depressive symptoms over the course of time and looking at subgroups. All right. So what are some of the limitations of our work and future directions? Well, one thing we need to take into account is this group tends to come from specialty clinics. They are largely Caucasian. They're relatively affluent. We are not able currently, or we've not been able to capture some of the kids that are not coming to these clinics. And so our next set of efforts is going to be trying to look to see where these other kids are going, because we're really pretty convinced that they're out there. We obviously need to begin to recruit families from different geographic areas, different parts of the country. We need to really start looking at the nuances of uncertainty. In other words, using probably a qualitative approach, looking at how these parents actually experience the uncertainty and what the actual sources are of the uncertainty. We need to continue to kind of look at some of the salient variables that predict resiliency in the face of uncertainty. And of course, what we will be doing is trying to look at the developmental trajectories of these kids, because we suspect that during critical time points, entering school, hitting puberty, we are going to see changes taking place in their psychosocial status as well as their parents' response, for all the reasons that you guys are well aware of. And certainly what we need to do is to take into account cultural factors. So again, we're biased, but we think that interventions that target uncertainty are warranted. Over the past couple of years, we've been looking to try and develop these new modules that are DSD specific. Courtney Wolf Christensen has been very involved in this endeavor. Hopefully over the course of the next year or so, we'll be able to kind of roll out an intervention and pilot it with a small sample of parents and begin to look to see if it's effective in attenuating their distress. Okay. Zoom doesn't lend itself to questions in the midst of everything. I don't know if people have been sending any questions to Cindy or chatting, but questions, comments. Amy, things I've left out?
I think that was a great presentation, Larry. Thank you. Yeah, I think we know our parents experience uncertainty, and I think you're absolutely right. We need to focus in on what exactly is concerning them. And I'm sure it's not going to be the same thing for all of our parents.
Takes a village, right?
Well, this was just really wonderful way to get us started with enhancing all of our knowledge and, you know, trying to think through some of how we can apply some of these cross-cutting pediatric psychology constructs and literature to this work, and then also really inspire us to think about some next steps and future research and just clinical practice. So thank you so much for your time.